It's a great pleasure to share my paper called Can Decision Support System Distort Human Capital? My name is Meizi Zhou. I'm from the Information System Department. This is a joint work with my co-author Xue Lin from Columbia University. So in recent years, there is a fast development of AI, and there is also an increasing concern over the associated risks about AI. In the literature, many work have shown that, for example, AI may replace human labor, AI may lead to product market concentration, or it can even lead to social inequality problems and so on. And from the regulatory perspective, there are also a lot of discussion. For example, the EU AI Act tries to call for more access into different areas of AI risks. So this paper kind of joins into this conversation. We are trying to show that how do humans' interaction with AI, especially if this AI, or like specifically in this paper, we study decision support system. When these systems are kind of manipulated, then how can it influence humans' behavior in the long term? So for decision support systems, these are the kind of systems that facilitate humans' decision-making in various aspects, and mainly they leverage algorithms to provide recommendations which facilitate humans' decision-making. And in this paper, we specifically study one phenomenon. I call it learning from algorithm, which means when users are provided by recommendations, these recommendations will not only affect their decision-making while these recommendations are present, but may also influence their long-term habit in the future when similar tasks happen and even after the recommendations are removed from the user's presence. So we think this phenomenon is kind of dangerous because naturally there could be errors, there could be biases in the algorithm recommendation, and even worse, in our paper we specifically show that companies may even intentionally manipulate these recommendations in order to alter the user's behavior in some certain direction. So in this paper, mainly we are going to first show that in some scenarios, even professionals with expertise may not always distinguish such manipulations in the algorithmic recommendation. And also, these type of algorithm-generated mistakes may also be reinforced by users' habit formation even after such manipulations are removed. So the context of this paper is in a clinical decision support system. Physicians use this type of software very widely, and specifically we study such a system where it facilitates physicians to prescribe opioids. We think this type of systems is important because first of all, it's widely used in the healthcare domain. It facilitates physicians to do prescribing decisions, diagnosing decisions, and even recommending different testing procedures. And also, the opioid is an important social sector, and in the past 2 decades, there's a very serious opioid problem in the US, so we think this context is quite important. And this type of decision support systems, they are usually integrated with a system called EHR system, Electronic Healthcare Record System. Just to give you some background of the event that we want to study in this paper. So starting from 2011, the US government highly recommend physicians to adopt the EHR systems just to help to do the digital transformation. So starting from that time, they provide financial incentives to encourage physicians to adopt EHR system, and they provide a list of certified EHR companies. Practice Fusion is one of them, and it's actually one of the most popular EHR systems back to 2016. So starting from 2016, this major vendor, Practice Fusion, they collaborated with a drug company called Purdue Pharma, and this company they want Practice Fusion to secretly embed a recommendation functionality to promote their own product. And so during 2016 to 2019, there is manipulated recommendation functionality secretly inserted into the practice fusion. And the user of this practice fusion, they do not need to do any interaction, then they will receive this manipulated recommendation. And after 2019, after the Purdue Pharma was bankrupted, this functionality then secretly removed from the practice fusion. So that's basically the timeline of the event that we are going to study. 3 periods in total. So before 2016, that would be the pre-treatment period. And during, like in the middle, that's the treatment period. And after 2019 would be the post-treatment period. So what specifically is this embedded functionality? Basically, this manipulated functionality would remind physicians the pain level of their patients, and also they provide a drop-down menu. In this menu, they intentionally add one additional option called opiate therapy to provide it as a treatment option for all the patients without considering the detailed situation of the patient. And during the 3 years of this this functionality usage, this CDS has alerted more than 230 million times, and they unanimously recommend Purdue Pharma's long-acting opiate to the physicians. And after 2019, the Purdue Pharma went bankrupted, but this practice fusion software is still in use afterward. So in order to study this event, we first collect data from the High-Tech Act, where we are able to know which physician adopt which EHR system. So for our study, the treatment group include all the physicians who adopt the practice fusion system. And we make sure that all of these physicians have used them before our treatment. And for the control group, we include the comparable neighbors of practice fusion users. So this would be the physicians who are in the same 3-digit zip code and same specialty and who use some EHR system that have the same functionality of practice fusion. And then we also collect how do different physicians prescribe their opioid. First of all, we collect data from the CMS Medicare data. And specifically, we look into how do physicians prescribe the long-acting opioid and short-acting opioid. To distinguish them, the long-acting opioid include all the products from Purdue Pharma's company. And for example, OxyContin. So this would be the product that are promoted secretly by practice fusion. And to do a placebo test, we also include the prescription for the short-acting opioid. So this would be the drug used for acute pain. They are not promoted by the practice fusion. And just for robustness, we also use another data set from a private insurance just to show the result also hold for the private insurance users. So just to quickly summarize our first finding, we found out during the short term, when the manipulated recommendations are present to the physicians, for the affected physicians who use practice fusion, they significantly prescribe more long-acting opioid. So it doesn't matter the number of claims, the total cost, the supply of this, all of these values increase significantly. But there is no significant effect for the short-acting opioid, which is not recommended by practice fusion. So I think the short-term period result shows that for the physicians who are the professionals with expertise in some certain domain, they cannot really distinguish such recommendations in the decision support system's recommendation. And more importantly, we found that in the long term, like after 2019, if we check the prescription level, it still remains very high compared with the pre-treatment period. So for the cost of long-acting opioid, it still increased by more than 30%. So this shows that the impact of this algorithmic recommendation is not only present does not only exist when the recommendations are present, they also change the physician's habit in the long run. So even after these manipulations are removed from the system, the physicians may still keep prescribing more opiate than before, which is quite disappointed. So that would be our first finding. Another interesting finding in our paper is that we found this impact from this algorithmic recommendation are quite different from financial incentives. So some of you may heard about it after the Purdue Pharma invented the OxyContin opiate. They already spent a huge amount of money in detailing. So they intentionally pay some physicians to prescribe this long-acting opiate. And that mainly happened like even before they collaborate with Practice Fusion. So therefore, we also check the impact of this financial incentive. And we found out for the physicians who receive financial incentive from Purdue Pharma, we can see the total number of recipients gradually decrease after 2015. So that is due to litigation concern and also because of their change of plan. They start to collaborate with Practice Fusion. They want to promote their opiate in a different way. So we found that after they remove, like they stop give financial incentive to the physicians immediately, like after year 2015, the total effect decreased, and there is no long-lasting and no persistent effect for prescribing more opiate. So that's what we found quite interesting because it shows that financial incentive doesn't really have such a long-acting impact and doesn't really influence the habit of the physician's prescription behavior. So to summarize, our paper tries to study what is the long-lasting impact of such decision support systems on humans' behavior. And we show recommendation biases or misinformation can be undetectable even by professionals with expertise and may sometimes be reinforced over the long term. And this effect is quite different from financial incentives. For physicians who are paid by the Purdue Pharma, they do not prescribe this opiate, long-acting opiate in the long term. So that would be the main finding of the paper. There are also more heterogeneity analysis and additional analysis in the full paper. I would just stop here and welcome any questions.
What do the doctors say when you tell them what you found out about this?
The doctors?
Yeah,
I think for the healthcare providers, they would have different opinions. So I think usually some of the physicians, they are overconfident regard of their expertise in some certain operations. But like this is from the data. So I would say like when the physicians take the recommendations or take the predictions from the AI, they may hold different opinions. But from the data, we do observe they can be influenced. And sometimes, even if there's like error, manipulation, misinformation in the recommendation, it is possible that they may neglect the existence of such problems.
I wanted to ask, is AI in healthcare also being regulated by FDA or is some other government entity looking into it?
Yeah, that's a very important question. I think currently for these AI devices, we still need more advanced regulations from FDA. A lot of AI devices are actually not regulated by FDA. And some of the especially it's a type of algorithm. So I think they are trying to develop more regulations regarding how can they test and verify the functionality of these devices. And also because the nature of this algorithm, they keep changing. So it's not like once you develop an algorithm, it's fixed. You keep collecting new data, you use the new data to update your algorithm. So the predictions can change accordingly. And also the prediction has a huge heterogeneity. So it would be very hard to verify for example, the accuracy or if there's any misinformation in such recommendations. I would say there's a lot of challenging in this area and it's still a very new area.
I have a clarification question and a question. First, the clarification question is, I assume in the decision support system, when it recommends the Purdue Pharma, it doesn't tell physicians like the reason, or it's more like just the name, the Purdue Pharma name just shows up, right? Versus in financial incentives, physician would be aware of, I would get money for that, or how much money I would get for that.
So first of all, the name of Purdue Pharma doesn't really show up. It's just they provide an option called opiate therapy, and it is used for treating like chronic pains. And usually for chronic pains, if you want to use opiates, the products are from Purdue Pharma's products. Otherwise, it would be the short-acting opiate, and it's for acute pains. So they didn't explicitly mention the name, but actually the products are from the company.
Thank you. Yeah, that clarifies my question. The difference between the decision support system and the financial incentive, there actually isn't.
Yeah,
And my question is there any way or is there any results on comparing the physician's age? Like, I would assume older physicians, they probably stick to their original behavior, whereas younger ones who just entered the field, they might benefit because they're now aware of this treatment, but they might harm because they're forming the way they're prescribing medicines to patients.
That's a good point. So I didn't mention it, but in the paper, we did some heterogeneity on the treatment effect, and we do find out for the physicians who are more experienced, meaning they have treated more patients who need such treatments, and also for those who are more senior, like whose age are more higher, they are less likely to be influenced by such recommendations. So the treatment effect on those physicians are smaller. Thank you.
I have a question. I'm a physician myself. Just want to ask whether you see any trends for the pain score. You said there is a display of 3 months difference, like three months prior pain score versus current pain score.
Yeah.
If the pain score increases versus decreases, does that change the prescribing behavior or not?
Yeah, that's a good point. So first of all, they intentionally add this pain score functionality just to remind the physicians the pain level of the patients. And then they do have some alert trigger, like if this pain score increase and if it's higher than 3 point, then they will show up this drop-down menu. Yeah, but they still, when this drop-down menu shows up, they unanimously provide these treatment recommendations. They don't really consider whether this treatment is suitable for this patient or not.
Thank you. Just building on the last question, it'd be interesting to see in the future if the physician's habits are built earlier in their career, which is why you said the older physicians, more experienced physicians,
Less likely.
Less likely?
Yeah.
If the current physicians who are younger in your study continue that behavior over time, are you planning any additional hypotheses or any additional research moving forward on this?
So currently, due to the data limitation, we are only able to observe this treatment effect 2 years after the functionality was removed. So it's not like a really long-term observation. But we do think that in the long term, it's hard to causally measure this because many things could happen. There's a lot of heterogeneity. We are not sure whether they use other AI or they are influenced by other factors. So I think it also makes sense to limit the observation period a little bit.
Thank you.
Thank you.
Well, great. If I could jump in with the last question. Interesting. Was the intent of the paper to compare financial incentives versus algorithmic nudges, or was that an unintended consequence of the research that you found the financial incentives were less valuable?
So I think the main purpose of this paper is still study how do humans interact with AI. Like how does this interaction with AI influence humans' behavior? That's the main purpose. I think the financial incentive is kind of a byproduct. It's just during the research we found out, actually it's very interesting. Like the Purdue Pharma, they intentionally separate the physician population when they try to do these two ways of promotion. So they first started by do the detailing, and then when they choose practice fusion, actually the physicians who use practice fusion are quite different from the previous physicians. They don't have a lot of overlap. So they are from different areas. And therefore we found out, maybe it's also interesting to study that aspect, and we actually found the opposite results.
Great. Yeah, because in a way, maybe there's a stretch, but it's almost a proof point of behavioral economics, right? That it's more powerful than rational economics.
Yeah, I think that have been found in some other existing literature. Like if you provide some financial incentive to trigger, for example, customers or even human to do something, it won't last long compared with other factors like social support or, yeah.
Excellent. Well, thank you.